Welcome again from Frankfurt, CCB, Markus Krankenhaus. My name is Julian Chun, and it's my greatest pleasure to invite you to the next session. And it's a very interesting session dealing or exploring the potential in the early experience of balloon-based PFA ablation. We have now a great session in store entitled Exploring the Potential Early Experience of Balloon-Based PFA Ablation. And we move on and meet our great faculty for the session. It is Arian Sultan, Cologne, formerly Cologne, now Hamburg, Germany, and Roland Tilz from Lübeck, UKSH. Welcome, both of you. And
Good afternoon.
for the case of the session, the operator, Gian Battista Chierchia from the UZ Brussels in Belgium, is unfortunately unable to join us live, but he kindly recorded the case presentation beforehand. So I would suggest, without any further delay, we move right into his case, and we will see what he can show to us using a balloon or a balloon-based PFA ablation approach.
Hello, everyone. First of all, I would like to thank Julian, Dr. Chun, for having introduced me. My name is Gian Battista Chierchia. I am the current director of the atrial fibrillation program in University of Brussels at the Heart Rhythm Management Center. And I will today present our first in-human experience with the balloon-based pulse field ablation system, the Volk PFA. Before we jump into the live case in the box, I would first of all like to walk you through what this system is. Now, this system is consisting of a 28 millimeter expandable balloon. It can expand with the injection of saline. Over these expandable balloons are built 8 splines, which have a 1.7 centimeter exposed portion of the slide, which will go in contact with the endocardium. All this is built on a catheter that is introduced in the left atrium through an Agilis sheath. This catheter also is visualizable on the 3D Insight mapping system and comes with its own Volt PFA generator. Why a balloon? Well, the balloon pushes energy field outwards. Computational modeling indicates that lesion volume might increase of up to 25% if compared to basket-shaped catheters. So this is what the balloon looks like in a cadaver model. You can see that it's nicely sitting in the axial position of a pulmonary vein. You can easily rotate it in order to create overlapping lesions that, as we know, contact, according to recent publications, is of extreme importance also when ablating with the pulse field energy. Now, the Volt PFA system comes with an impedance-based algorithm that indicates the amount of contact that a given spline has with the endocardium. This algorithm is called live point tissue proximity. Now, if you have optimal contact, meaning that a large portion of the spline is in contact with the endocardium, you will see the circle, the portion of the circle of that spline. You see the numbers on the outside circle will be blue. If you have a lower amount of contact with that given spline, well, the contact will be considered as suboptimal, and it will come out in a white color on this circle. That doesn't mean that if you have suboptimal contact, that the spline is not perfectly in contact with the endocardium. What it just means that a smaller portion of this 1.7 centimeters that are exposed on the spline is in contact with the antrum. but the lesion will be given successfully anyway. Another important thing is before starting to ablate with a Volk catheter, you need to baseline this catheter. This process requires an initial baselining as local impedance varies from patient to patient. The balloon must be inflated prior to contact with the endocardium, and then you should wiggle it around in order to position every spline, that every spline has contact with the endocardium sequentially. And once you have obtained this, the inner circle will become green, and you are ready to go. Again, coming back on the light point tissue proximity algorithm, what you will see when you move your balloon around the antrum of the pulmonary veins are these dynamic bars that are moving out from the center as the tissue proximity increases on a given spline. That means that if a sufficient amount of that spline is in contact with the endocardium, what happens is that dynamic bar might cross the impedance threshold and make the contact there optimal. The Volk PFA journey to first-in-man, initially the design of the catheter was a lasso-like design, which was difficult to position. There was significant patient movement. There was SD segment elevation, and you could see gas bubbles. Various morphologies were analyzed in time until we came to the balloon-based morphology that you see today, which ensures durable lesions, minimal movement due to optimal contact, and up till now, and in preclinical studies, no evidence of thermal necrosis. We had the luck to participate to the first-in-man study. 150 subjects were included in up to 20 sites. Acute effectiveness was considered electrical isolation of all PVs. And as you can imagine from this kind of trial, freedom from documented AF or any atrial tachycardia of more than 30 seconds was considered successful. Now, before we go to the case in the box that I prepared for you today, I would like to introduce the setting. So the setting, as you will see, you will have a white. So you have simply an electrocardiogram. You will have purple electrograms indicating the recordings on the balloon surface, and light blue electrograms, which are the additional catheter that we use usually to position in the CS, but also to pace the phrenic nerve, because this was a requirement of the study, even if we know that the PFA does not create irreversible lesions to the phrenic nerve. So let me jump into the case. You would see a 3D electron-anatomical pre-ablation map that we have created before we started the ablation. This was another requirement of the study. So this, you see, we're preparing the balloon in saline. We're inflating it in saline. You see the splines that are opening up and being assisted by Dr. Benta. And you see where we are performing a 3D high-density electron-anatomical map with an HP grid prior to inserting the balloon. Now, the balloon is inserted in the left atrium. We see now the baselining process, and I have introduced you in the slide before. So you will see that we are wiggling the balloon around in order to gather information of the impedance information of this given patient on every spline. And now we are ready. We have all the green circle inside, and And so we are ready to go. Now, please concentrate on the purple electrograms. What you will see, the balloon is positioned in the LSPV. You will see now a scopical image of it. And you will see, be careful of the purple electrograms, because once we give a PFA, they will disappear instantaneously. As you can immediately see, they have disappeared. Okay, so each ablation consists of 10 pulses that are gated on the ventricle. So by giving atropine, we can make the procedure faster because we increase the heart rate. So the 10 pulses are being given. You see the balloon snugly into the LSPV. And once the lesion is terminated, you will see, yeah, there you see dotted indicators of where we have ablated. So it was advised to give 2 ablations per vein. As you can see, we're moving by around 15 degrees in order to position the splines exactly in the middle of the dotted of the dots of the previous ablation. This is more in the antral position in order to have a nice antral lesion. And so once we're happy with our position, we give the second application in this vein. It's always important to position the splines in the middle of between the previous dots, because it creates a nice overlapping lesion. As you can see, you can, by a very swift movement, positioning it into the LIPV. You don't need to retract it in the sheath. And once we're in the LIPV and we're ready to ablate, and we just position and leave the balloon in that position, and we give again these two lesions in this vein. Have you seen it? Have you seen the electrograms disappear immediately? And we just have to wait for these 10 pulses, these 10 gated pulses. It's a very straightforward and easy procedure to perform. And there you go. So again, same thing. We rotate by 15 degrees. We position the splines in the middle of the previous ablation dots, and then go for the second ablation in this vein. You see a countdown on the circle, and we're ready to go. Again, 10 pulses in order to create a more antral lesion. Here also, what we typically do is a more proximal, a more distal lesion in the vein, and then successively a more antral region. Now you will see that we will approach the right side now by simply moving the balloon inside the RSPV, as you can see, without retracting it in the sheath. This is sped up for the sake of time. As you can see, the balloon is snugly positioned on the LS and the RSPV. Again, same thing, more distal and then more proximal. The second lesion more proximal, in order to create that nice antral lesion. The only vein in which we tend to retract the balloon into the agilis in order to then approach it is the RIPV. But it's a very swift and easy maneuver. And here again, you will see ablation. Now, I just give you this example of we're testing now the phrenic from the balloon. Pacing this was required again by the study. We did this in the RSPV, but I didn't show it before. And then once we saw that the phrenic was absolutely not being captured by pacing from the balloon, we proceed to ablation in this vein. Once everything has been ablated, we retrieve the balloon inside the agilis, and then we perform a 3D electroanatomical map. As you can see, the lesion is absolutely antral, well beyond the dots. The dots are only an indicator of where the balloon has been, absolutely not an indicator of the antrality of the lesion. You see pre and post, you clearly see the difference. So we're extremely happy with this technology. I would like to thank you for your attention. Thanking again Dr. Chun for having introduced me, and I wish you goodbye.
Yeah, wonderful. Thank you very much, Gian Battista, for this beautiful and very elegant presentation of the case. And I suppose we just jumped right into our panel discussion. But before, I would like to still remind the audience, you can enter Q&As, whatever you have, whenever you have a question, just put it in and we will try to answer all of them. Ladies first, Arian. What are your first thoughts once you see this beautiful case and listening to his explanations?
Yeah, dear Youngie, thanks for the question again. Thanks for the organizers of having me. But yeah, I mean, I think it's the next step of a new disruptive technology. And now we are able or enabled with things that we were missing. Let's say with other PFA tools, we have some information about the anatomy. We get some 3D mapping. Without using a different system, all in one system. And also we get some feedback on contact and some feedback on lesion creation. I think these are things that I would say the majority of us were potentially missing with other systems. And I think it's a step forward. However, to me, it appeared a bit bulky, and I'm just wondering how it would look and feel like in a small left atrium. But as I heard from other users, it's not that bulky as it seems. So it seems to be easy to maneuver. I think Roland already used it, so he might give us some insights on that. But I think it's a step forward in terms of we get to learn what we're really doing while we are delivering PFA in those patients.
Yeah, that's a good point. Roland, you have been a big member also of the balloon idea, using balloons to ablate AF. So what are your thoughts? And we know you also have in your center personal experience.
Yes, so first of all, congratulations to this wonderful case. And I think it's a really amazing technology. It has the advantages of the balloon technology. And I think the balloon, it's a very safe technology. You can also push, you can get a very good wall contact, which we know is crucial for lesion durability. And you can get it integrated into a 3D mapping system. You're right, Arian. The first generation was a little bit bulky. The second generation is a little bit less bulky. But what does this mean? It means that you have to adopt your workflow to this different design. So what we do is a cryo balloon, you inflate, you deflate. The Volk balloon, we would keep inflated throughout the entire procedure. We would pull back the sheet to the right atrium, and just you can nicely maneuver the inflated balloon and even cannulate the right inferior balloon with the inflated balloon. So you have to learn how to adopt your workflow. But maybe I think another thing is that you have a lumen, but it's not designed to give contrast. So you use it in the 3D map, but you don't confirm contact with contrast. You confirm contact with the impedance. But maybe I would like to have forward one question. What you did not mention in your presentation, it's concerning the ablation protocol. So you mentioned that we had to pace all electrodes before we delivered PF energy. And maybe you can just highlight what we did when we could capture the phrenic nerve. So what was the impact?
Yeah, Roland, thank you for bringing up and summarizing your experience. I think Gian Battista, he was a recorded case. I'm afraid he's not live with us right now.
Or are you? Then I can answer the question. If he's not here, okay. Sorry, if he's not live, I can answer it. Because I think he nicely demonstrated that before we delivered the energy, we had to capture every electrode. And if we could capture the electrode, we just reduced the power and gave an additional application. So basically, that's what we did. But there was no phrenic nerve palsy documented so far.
Yeah. Thank you for this update on this. Roland, maybe I also have one very practical question or two questions. It is, I'm not personally familiar with this device so far, but is there also the option to select or deselect a certain, let's say, splines in order to ablate, or is it full circle, always full circle? This would be question number one.
Yes.
And the question number two, in your experience, you mentioned also workflow and also contact as an important tool or to the important component. Did you observe sites of less good contact, more reconnection as compared to sites with perfect contact? Also elaborating more on the role of contact for PFA in general.
So, I mean, we have done a redo procedure. So I think the redo numbers are very, very limited, but the durability rate was very good. So I think that this is one strength. I think the data is very, very preliminary. But to my knowledge, I think the durability rate was extremely high in redo procedures. And I think one major reason is because you can get a very well contact with this balloon technology. But we don't have a large number of patients with redo procedures so far, so we can't confirm whether the durability rate is better as compared to other technologies so far. What was the first question again?
The splines.
Yeah, whether you can select and deselect. Yes, you can do it with technically it's feasible, and we did it in pigs. But within the protocol, within the Volk study, you were not allowed to deselect electrodes. So we always had to deliver the energy through all electrodes. With the outside the study, it's technically feasible, and you can do it. So if you, for instance, in the future may consider to ablate posterior wall, you can just select the electrodes which are in close proximity, but deselect the electrodes which are facing anterior.
Yeah, wonderful. So there's more to come and more interesting updates. Arian, switching and coming back to you. We already highlighted now a lot of those advantages, but do you also see maybe disadvantages or limitations of a balloon design as compared to, let's say, a maybe more versatile?
Yeah, that's a good question that I ask myself. Where is the position, or where will be the value of this technology in the concert of all other devices that we have in our hands? And I do see all the potential of this new technology, as Roland has pointed out so nicely, and we've seen in the case, and also with the possibility of being selective. I think there's a lot of possibilities. However, having said that, when I think of other things I might want to do outside the pulmonary veins, and as Roland already confirmed that it can be a bit bulky in smaller atria, I'm just wondering how feasible it will be to use the catheter for other indications outside pulmonary vein isolation. Just top of my head, for posterior wall, I think it would be feasible, still quite easy. But for any other thing, lines, etc., I think we will see the same limitations that we have seen with other balloon technologies or single shot devices, that they're obviously not constructed to do something like that. However, I think we have a lot of other tools in our hands to deliver those things. I think it's, as Roland said, it's an exciting and I think disrupting technology with its limitation due to the architecture of the catheter itself.
Maybe if I add
one comment. Roland, do you want to comment? Yeah.
Yes, I mean, if you're talking about single shot devices for pulmonary vein isolation, I mean, all of us have used so many, seen and used so many different catheter designs, no matter whether it's a circular catheter or any other shape. And the only shape and the only design where I get consistent, nice wall contact is the balloon design. So this is why I'm a very big balloon believer. So I think with the balloon design, you can get in an oval shaped anatomy, consistent, good wall contact, which is crucial even in PFA technology to get durable, reproducible lesions. You may ablate also the posterior wall with this catheter, but it's not designed for any additional application. So like lines, isthmus, anterior line, that's not what it's designed for. And I think all other single shot devices should not be used at present time for those indications.
And on top, of course, so far at least, PVI remains what we are doing, at least in these procedures. maybe just one other question for both of you with regards to safety. And I think Gian Battista mentioned briefly and touched on this because of the balloon design. And I think this is a very, at least I can understand it. The energy is shooting basically away from the blood. And your experience, very brief, haemolysis, zero problem or something still some concern?
So we have the data and we submitted the data for different meetings. And just what I can tell you, it's not an issue.
And I think
you
it's
deliver
nice.
the energy to the tissue, but not in the blood pool. There is a lot of experimental data which shows that you have much less hemolysis if you delivered it just in the tissue and not randomly into the blood pool. And I think it is in line with our clinical data.
What is the typical case duration and what are the typical applications per patient, just roughly?
So Gian Battista also mentioned that per protocol, you had to apply 2 applications per vein. So just because in order to get overlap between the lesions. So this was the idea, why 2 was the minimum. We started in Lübeck early to establish 4 as a standard of care. So 2 to isolate the veins, once like this, once like that. And then we pulled the balloon a little bit back to get a little bit more entry lesions and added another 2 applications, one like this, one like that, similar to what we know with the purples catheter, where you also rotate the catheter. So at our lab, 4 per vein was the standard of care. Within the Volk study, it was on average 4 as well, but 2 is the minimum. The duration in the Volk study was rather long. It was longer than an hour, but this was due to a very long and detailed protocols. You had to do a map of the SVC. You had to paste the SVC. You had to map the left atrium. You had to paste from every electrode before every application at the right-sided vein. But I think ultimately, it's like most procedures, if you just streamline the workflow, it's going to be somewhere between half an hour and an hour. Similar to a trial.
Thank you very much. Last word, Arian, and then we need to wrap up.
And in terms of hemolysis, I think that the fact that you get tissue contact feedback omits you from delivering too much energy as opposed to other catheters where you do not have an idea if you have a clear contact to the tissue and therefore PFAing the blood pool a lot. So therefore, I think it's another safety feature.
Yeah, wonderful. Thank you both very much. And this is a beautiful bridge because we will meet again in the next session. And first of all, I would like to wrap up this session on a very exciting balloon technology. Balloons are interesting for pulmonary vein isolation. And for sure, this is something very exciting. And we need to thank, of course, Gian Battista for showing and his team for showing this nice case. And yeah, I think it was a great session, and we will see each other again in a couple of minutes for our next session, and we will welcome then Vivek, and we will speak about safety of PFA. See you in a second.
Thank you so much.